dioxide on the release and uptake of oxygen is? Options are Bohr's effect, Aldane's effect, Venturi effect, Wind-Kessel. Loading of oxygen. Okay, so there will be loading of carbon dioxide and there will be unloading of oxygen. So where does it? The oxygen will unload or release the oxygen. Hemoglobin will release the oxygen. So it is the ulta. Okay, loading or loading of oxygen. This takes place at the lung level, alveolar level. Okay, you will have transverse diameter, vertical diameter, and all of the above. And so this bucket handle movement, you can see whenever there is contraction of the So the next question is, pump handle movement of the ribs causes external intercostal muscle that is attached to the upper ribs will rotate the sternum upwards and outwards, thereby increasing the anterior-posterior diameter. Okay. So the next question is, all are the characteristic features of vesicular breath sound except. Okay. So you have two types of breath sounds. So we discussed all these things in the clinical examination of respiratory system. Okay. So you have bronchial breath sound and you have vesicular breath sound. So normally over the chest you can see you can hear the vesicular type of breath sound. Okay. Over the trachea you can hear the bronchial type of breath sound. Okay. Normally. So whenever you are going to hear the bronchial type of breath sound over the chest wall, it is abnormal. Okay. So the sound that is there in the trachea will be filtered by the lung tissue and it becomes low pitch rustling sound. Okay. So what are the characteristic feature of this vesicular breath sound means? So normally you can hear all over the chest wall. Inspiration is prolonged than the expiration and there is no gap between the inspiration and expiration and it is low pitch sound. Okay, when compared to the bronchial breath sound. So the options are heard all over the chest wall, high pitch sound, has rustling character, duration of inspiration is prolonged. So all these are the characteristic feature of the vesicular breath sound except high pitch sound. Okay, it's a low pitched sound. So next question is, intrapleural pressure is more negative at the apex than the base of the lung in the upright position, base than the base in the upright position. This is because of the effect of gravity. So around 0.25 you will have the intrapleural pressure at the base, means -10 will be at the apex. So you can expect more negativity at the apex when compared to the base in the upright position because of the effect of gravity. Okay. So next question is, the normal intrapleural pressure is -11 to -14 centimeter of water, around -5 centimeter of water during the expiration and -8 centimeter of water during inspiration. Okay, so the next question is, hyaline membrane disease is caused due to the deficiency of renin, gastrin, surfactant and cerebrospinal fluid. Okay, so renin is concerned with the renal system, gastrin is concerned with the gastric acid secretion, and CSF is present in the spinal cord and the brain. So the answer is surfactant. So surfactant is a substance which decreases the surface tension. So whenever hyaline membrane disease is usually seen in the newborn babies. So whenever the baby is born, so what will happen? It makes a strong inspiratory effort so that it can expand the lung. Okay, it will expand the lung, but the lungs has a tendency to collapse. Okay, so this is prevented by the surfactant. Surfactant will help in the inflation of the lung and it also prevents the collapse of alveoli. Okay, so whenever this is absent, okay, so the baby, the inspiratory effort should be very strong and even the lungs expand also, they will collapse. So the respiratory movements becomes labored. So that is called as hyaline membrane disease. It's mainly because of the Deficiency of surfactant. Surfactant is a substance which lowers the surface tension. Next question is the dorsal respiratory group of neurons is present. Pons, you have the pneumotaxic center and apneustic center. So the dorsal respiratory group of neurons is present in medulla. So it contains mainly the inspiratory neurons. Okay. Next, the ventromediastic center is, it coordinates the respiration by switching between the inspiration and expiration, and it also inhibits the apneustic center. Apneustic center is present in medulla, pons, hypothalamus, thalamus. Answer is pons. So whenever you stimulate, it is inhibited by substance P. It is stimulated by opiates and considered as the pacemaker of respiratory system. It is present in between the nucleus ambiguous and lateral reticular nucleus, and it is considered as the pacemaker because it generates the normal respiratory rhythm. Okay, it rhythmically discharges, okay, so that it can rhythmically activate the phrenic nerve. So the answer is, it is considered as a pacemaker of respiratory system, okay, because it generates the normal respiratory rhythm. Next question, A.S. Penthal, an Indian scientist, discovered lung irritant receptor, J receptors, baroreceptors and chemoreceptors. So he discovered J receptors which are present in the pulmonary interstitium. So answer is J receptors. Okay. Exposure to high altitude causes no change in breathing pattern, Bayard's breathing, Kussmaul's breathing and chain stop breathing. Okay. So unacclimatized person, if he goes to the high altitude, so you are going to expect chain stop breathing. Chain stop breathing is an abnormal breathing where you will have hyperapnea followed by apnea. So usually it is seen in the premature infants and unacclimatized person at high altitude. So whenever the person is suffering from renal failure or heart failure, so you can expect chain stop breathing. Next question is, the type of breathing seen in diabetic ketoacidosis is normal breathing, Bayard's breathing, Kussmaul's breathing and again Bayard's breathing. Okay, so the answer is Kussmaul's breathing. So Kussmaul's breathing is a characteristic breathing that you can see in diabetic ketoacidosis, which is nothing but rapid and shallow, okay, breathing. So you can expect hair anger. The next question is, type of breathing in which there is alternate eupnea and apnea is called as normal breathing, Bayard's breathing, Kussmaul's breathing. You can expect in meningitis, increased intracranial pressure, morphine poisoning and all. Okay, so the next question is, hypoxia causing damage to the cytochrome oxidase enzyme system is. So what is hypoxia? Hypoxia is nothing but decreased partial pressure of oxygen at the tissue level. Okay, so you have different types of hypoxia. You have hypoxic hypoxia because you will have decreased partial pressure of oxygen, and you have anemic hypoxia, that is decreased hemoglobin level. So hemoglobin is the carrier for the oxygen to the tissues. So even if the hemoglobin is less, you can expect hypoxia. Hypoxia is decreased oxygen level at the tissue level. Then next is you have the stagnant hypoxia. Even though the partial pressure of oxygen and the hemoglobin is normal, okay, you need the proper circulation, blood flow to the tissues so that the oxygen reaches the tissue. So if there is stagnation or sluggish blood flow, you can expect the hypoxia because of decreased blood flow. That is called as stagnant hypoxia. Last one is histotoxic hypoxia. Even though the partial pressure of oxygen is normal, even though the hemoglobin concentration in the body is normal, even the circulation is normal, the tissue cannot utilize, okay, because of some abnormalities. Okay, for example, if there is cytochrome oxidase enzyme system inhibition, okay, the tissue cannot utilize the oxygen that is there in the surrounding. That is called as histotoxic hypoxia. So the options are hypoxic hypoxia, anemic hypoxia, stagnant hypoxia and histotoxic hypoxia. So the answer is histotoxic hypoxia. Next question is, the true statement regarding cyanosis is: peripheral cyanosis is seen in tongue. Central cyanosis occurs in severely anemic patients. Cyanosis does not occur in anemic hypoxia. Cyanosis is seen in left to right shunt. So the answer is cyanosis does not occur in anemic hypoxia. Why means because hemoglobin is very less. You need a certain level of hemoglobin, deoxygenated hemoglobin, for the occurrence of cyanosis, peripheral and central. So peripheral cyanosis you can see at the fingertips, okay, nail beds and all. Whereas central cyanosis you can see in the tongue, lips and all. Okay. So the next question is, periodic breathing characterized by alternate apnea and hyperventilation. So as I discussed before, it is chain stop breathing. So you will have hyperventilation followed by a cessation of respiration, which is apnea. Same thing continues. Cyanide poisoning is an example of hypoxic hypoxia, anemic hypoxia, stagnant hypoxia, histotoxic hypoxia. The answer is histotoxic hypoxia. So this cyanide poisoning will inhibit the cytochrome oxidase, so which will not allow the tissue to utilize the cytochrome oxidase is necessary for the utilization of oxygen. So the answer is histotoxic hypoxia. Next question is, the method of artificial respiration term iron lung is mouth to mouth breathing, Schaeffer's method, Ogler-Nielsen method, tank respirator. It is tank respirator. Okay. So the partial pressure of oxygen in atmospheric air at a high altitude of 10,000 feet above the sea level is 159 mm of Hg, 110 mm of Hg, 73 and 47 millimeters of mercury. Answer is 110. See, at that sea level, the partial pressure of oxygen is 159 millimeter of mercury, whereas at 10,000 feet it will be 110 mm of Hg. Next question is, the gas that is responsible for the causation of decompression sickness is oxygen, carbon dioxide, nitrogen and helium. Okay, so decompression's answer is nitrogen. Decompression sickness is nothing but whenever you go diving to the deep sea. Okay, so what will happen? All the gases is barism and all, bends and all. So the next question is, J receptors are present in walls of alveoli, pulmonary, capillary walls, walls of the trachea, pulmonary interstitium. So this J receptors, they are present in the pulmonary interstitium. They are juxta alveolo-pulmonary receptors. They get activated whenever there is congestion, edema and all. Okay, so when they get stimulated, you will have the bradycardia and all. Reflex tachypnea, there is more and more breathing and bradycardia you can expect. Next question is, residual volume is equal to dead space volume, amount of air in the lungs after maximal forceful inspiration, amount of air remaining in the lungs at the end of normal expiration, total lung capacity minus vital capacity. It is the total lung capacity minus vital capacity. So what is this residual volume? It is the amount of air that is remaining in the lungs after forceful expiration. Okay, after forcefully you expire, also some amount of air that will be left in the lungs, that is called as residual volume. So it is the total lung capacity minus the vital capacity. So the normal value will be around 1.2 to 1.5 liters. So the third option is the forced functional residual capacity, amount of air remaining in the lungs at the end of normal expiration. So second option is amount of air in the lungs after maximal forceful inspiration is vital capacity. Sorry, it is the inspiratory capacity. So the answer is total lung capacity minus vital capacity will give you the value of residual volume. So what is vital capacity? Amount of air that can be inspired forcefully after amount of air that can be expired forcefully, functional residual capacity and forced expiratory volume at 1 second, first second. So the answer is functional residual capacity. Okay, when fully saturated, each gram of normal hemoglobin contains dash ml of oxygen, 1.34, 13.4, 134 ml, 0.3 ml. So the answer is 1.34 ml. Okay, so each gram of hemoglobin will carry 1.3 ml of oxygen with it. Next question is oxygen dissociation curve shifts to right in all of the following except fall in 2-3 dpg, raise in temperature, fall in pH, increased carbon dioxide content. So you have this oxygen dissociation curve whenever it is shifting to right side, means the hemoglobin loses the affinity and there will be unloading of oxygen. Okay, so shift to left means there will be more affinity of oxygen for, there will be more affinity for oxygen by the hemoglobin. Okay, there will be loading. So you can expect this shift to right whenever you have increase in 2-3 dpg level, whenever there is increase in temperature, increase in H plus concentration, that is nothing but fall in pH, and whenever you have increased carbon dioxide content. So the answer is fall in dpg. Fall whenever you have decreased level of 2-3 dpg, you are going to expect the OD curve to shift to left, not to right. Okay, next question. Pulmonary J receptor stimulation results in reflex tachypnea followed by apnea and bradycardia, reflex apnea followed by tachypnea and bradycardia, reflex tachypnea followed by apnea and tachycardia, reflex apnea followed by tachypnea and tachycardia. So the answer is reflex apnea followed by tachypnea and bradycardia. Which of the following is not the metabolic function of the lung? So you have the non-respiratory functions of the lung, in that you are going to expect in the lungs, and it also causes inactivation of certain substances like prostaglandin, bradykinin, serotonin and all. And coming to the formation of angiotensin 2, angiotensin converting enzyme is present in the lungs, so which helps in the conversion of angiotensin 1 to angiotensin 2. So the third option also is correct. So only the inactivation of vasopressin does not occur in the lung. Okay, so the correct answer is inactivation of vasopressin. Next question, which of the following is true about myoglobin? Myoglobin binds to 4 moles of oxygen per mole. Myoglobin oxygen dissociation curve has a parabolic profile. It has a high affinity for oxygen compared to that of the hemoglobin. Myoglobin hemoglobin dissociation curve shows Bohr's effect. Okay, so myoglobin, 1 mole of myoglobin will bind to 1 mole of oxygen, and myoglobin oxygen dissociation curve will show parabolic profile. Okay, and it will not show the Bohr's effect. Only the correct statement in this question, in this option is it has higher affinity for oxygen when compared to hemoglobin. Under resting condition, the total oxygen consumption is 100 ml per minute, 150 ml, 200 ml, 250 ml. Answer is 250 ml per minute. Adequate oxygen is delivered to the tissue in which type of hypoxia? Hypoxic hypoxia, stagnant hypoxia, anemic hypoxia, histotoxic hypoxia. As I told before, you need the normal partial pressure of oxygen, okay, then for the delivery of oxygen to the tissue, and you should have the normal hemoglobin, and you should have normal blood circulation, and the tissue should be normal, okay. So they have asked adequate oxygen is delivered to the tissue. So all these things should be, first three things should be correct. That is, the PO2 of oxygen should be normal. That will rules out the hypoxia. Then the blood circulation should be normal. That will rule out the stagnant hypoxia. Hemoglobin also should be normal to carry oxygen. So you will have the hypoxia. So the answer is histotoxic hypoxia. So the next question is, the alveoli are normally caps of the alveoli. The gas that is used to measure the diffusing capacity of the lung is carbon monoxide. The gas is transferred, okay, that is called as diffusing capacity. To measure this monoxide, physiological shunt refers to ventilation, perfusion in excess of ventilation. Next question is, the normal PO2 in the venous blood is 40 mm of Hg, 60, 80 or 90, 116 mm of Hg. In the arterial blood, it is 95 mm of Hg, whereas in case of venous blood, you are expecting 40, or you can see 40 mm of Hg of partial pressure of oxygen. Small airway resistance is best measured by FVV1, closing volume, total lung capacity, or forced expiratory flow rate at 25 to 75%. So the answer is the FEF 25 to 75%. So it is nothing but the forced or the maximum flow rate observed or measured between 25 to 75% of the lung volume. Okay, so this will measure the small airway resistance. Okay, so FEV1 is nothing but your expiring forcefully, you are going to expire. So whenever you have time, that is 1, 2 and all, means at first second how much amount of air that is expired, that will give the FEV1. So you have another term which is called as FEF 1200 to 2000, that will measure the large airway resistance. Okay, so in moderate exercise, tachycardia and tachypnea is due to the proprioceptive impulses from the joints, increased PCO2 in the arterial blood, decreased PO2 in the arterial blood, or decreased pH. So whenever you start up the exercise, whenever you do certain mild to moderate exercise, immediately the receptors that are present in the joints, which are called as the proprioceptors, they'll send signals. So you are going to have the increased heart rate, increased respiration. Okay, so the answer is proprioceptive impulses from the joints. Next question, sudden cessation of respiration at the end of forceful expiration is due to dynamic compression of airways, collapsed alveoli, expiratory muscle fatigue, braking action of inspiratory muscle. So it is because of the compression of the airways. Okay, forcefully whenever you expire, it will compresses the airway, so you can expect a brief apnea. Next, which of the following has high affinity for hemoglobin, carbon dioxide, arterial oxygen tension occurs? Anemia, carbon monoxide poisoning, moderate exercise, and hypoventilation. Answer is hypoventilation. So whenever you are not respiring, okay, decreased respiration will result in decreased oxygen or PO2. Okay. Which of the following condition leads to tissue hypoxia without alteration of oxygen content of the blood? Carbon monoxide for oxygen level in the blood, whereas carbon monoxide poisoning, because it has high affinity, it will displace the oxygen by binding with the hemoglobin. Okay, so it will decrease its oxygen content. Even the methemoglobin will not have the affinity for oxygen, and even respiratory acidosis also will decrease its oxygen content, except the cyanide poisoning. Okay, all this will decreases the oxygen content of the blood. Okay, only the reduced diffusion capacity, reduced total lung capacity. It is reduced FVV1 to FVC, forced vital capacity ratio. Interstitial lung disease will result in decreased. Okay, so interstitial lung disease, in this you have the inflow will be altered, not the outflow. So you're going to expect the reduced FVV1 by FVC ratio. Surfactant production in lungs starts at 28 weeks of intrauterine life, 32 weeks of intrauterine life, 34 weeks, 36 weeks. So it usually starts at around 28 weeks of intrauterine life. Oxygen dissociation also will shift the curve to the right and increase 2,3 dpg. So the diabetic ketoacidosis, increased body temperature and increased 2,3 dpg level shifts the OD curve to the right side except the blood transfusion. So the answer is blood transfusion. Compared with the apex of the lung, the base of the lung has same ventilation perfusion ratio, higher pulmonary capillary PO2, lower VP ratio and higher pulmonary capillary PCO2. The answer is lower VP ratio. Okay, so the normal VP ratio is 0.8. You are going to expect around 0.6 to 0.5 in case of base, whereas you are going to expect higher VP ratio in case of the apex. Next question, carbon dioxide is carried in venous blood mostly in the form of carbonic acid, bicarbonates, dissolved carbon dioxide or carbamino groups. Okay, so it is transported. The most important respiratory stimulant is oxygen, carbon dioxide, K plus ions, H plus ions. So always the answer should be carbon dioxide. Carbon dioxide is the potent stimulus for respiration. Type 2 pulmonary epithelial cells will secrete the mucus, polypeptides, serotonin, surfactant. It is the surfactant. Surfactant are secreted or synthesized by type 2 pulmonary epithelial cells. The lung volume which cannot be measured by using spirometer. So I discussed this one before only. So the options are residual volume, vital capacity, inspiratory reserve volume, tidal volume. Except residual volume and FRC, you can measure all other values of the lung volumes and capacity by using the spirometer. So the answer is residual volume. Oxygen content of saturated arterial blood is 11.2 ml per 100 ml, 25 ml per 100 ml, 19 ml per 100 ml, 14.5 ml per 100 ml. So the answer is 19 ml per 100 ml. The respiratory center hemoglobin to the oxygen, loading of oxygen. Okay, so increase in body temperature will shift the oxygen dissociation. The answer is increased pH. Okay, increased pH means decreased H plus ions. It is increasing in value because of decrease of H plus ion. Oxygen is supplied to the tissue. Tissue is not in a position to utilize it. So how much ever you give the oxygen externally also, it is of waste because it is okay. So at first second, how much amount of air that comes out will be is FVV1. So normal is the property of stretchability of the lung. Okay, so it is nothing but stretchability or distensibility of the lung. So obviously fibrosis, tension and atelectasis. So the answer is emphysema. Other than emphysema, all other options